Mark Hobraczk. I'm the Senior Manager for Policy with HFA, and just wanted to talk to you for about 30 minutes this evening about an issue that has been one of our policy priorities for a number of years now. That's copay accumulators, but really focus on the emerging issue that we're seeing, which is the copay maximizers. Next slide, please. Now we're going to talk a little bit about what they are. I know most people that are attending are probably pretty familiar with accumulators, probably not so much maximizers. So we're really focused on how maximizers are different, but how both of them have a very severe impact on people with bleeding disorders, or really anybody with a costly condition. And then, of course, cover what's being done at the state and federal level to try to protect consumers from both models, and what you could do as an individual consumer to try to identify whether these are in your plan, how to possibly avoid them, and what you can do if they are unavoidable, if you have no plan options without them. Next slide, please. Now, basically, just as a very brief overview, copay accumulators, the actual name is Copay Accumulator Adjuster Programs, just a very complicated name to describe the latest cost containment tactic where your insurer is basically trying to make the plan as unaffordable as possible for people with the highest cost conditions. So really just another avenue of discrimination that they've opened up once the ACA required them to cover everybody regardless of health status. And it's very simply where they deny you any benefit whatsoever from the third-party assistance that you receive from a manufacturer. And we'll really focus on the manufacturer assistance. Obviously, there is assistance available from nonprofits, but typically we've seen this so far attack the copay assistance from manufacturers. And what they do is they simply don't credit any of the assistance that you get from that third party towards your cost sharing obligation. So that's your annual deductible, your annual maximum out-of-pocket limit. They will take all of that money. They're not refusing it. They're not rejecting it. They're pocketing it for themselves. It's going right to their bottom line. And as an example of how egregious this is, a fairly relatable example that we typically use is, imagine if you received a third-party scholarship for yourself or your son or your daughter to go to a college they couldn't otherwise afford. And when they showed up there the first day, the college said, well, we're happy to take that third-party scholarship, but if you want to go here, you're going to have to pay the full amount right now. And that just shows you, how unfair that is for the consumer and what's exactly happening in the copay accumulator case. Next slide, please. So who's at risk of encountering these? Well, almost everybody now. A couple years ago, it was still only a handful of smaller plans that we saw applying this. That's really exploded in the last few years to the point where, according to Avalar Health, at least 83% of people in private commercial health plans, so not Medicare, not Medicaid, the private plans are being hit with accumulators, and about 73% now are being hit with maximizers, which we'll go into in a minute. So if you're not having one of these applied to you yet, chances are very good that you will in the near future. And so it's really something to watch out for when you're going through open enrollment and selecting your health plan. Even if it's a marketplace plan, you've got 35 marketplaces, so more than 2/3 where there is at least one plan currently applying accumulators. And in 8 of them, every single plan is applying a copay accumulator. Florida, for example, has 14 insurers competing, and every one of them has some form of copay accumulators that they're applying. So impossible here, where I'm located, for a subscriber to avoid it. And they're very hard to find. It's really difficult for somebody to even figure out if this is something that's they're going to encounter during the plan year. So even if they have somebody with some expertise helping them, these can be buried on like page 120 of a 300-page plan document, put in the footnotes, called all types of things that sound beneficial for the patient, things like specialty copay solutions, copay protection programs. It's really difficult. You're not going to see the word copay accumulator usually in the plan. It will be called something else. And what makes it even harder is it's very often discretionary. The plan will say something like, we may apply this at any point during the plan year. We've had insurers, Florida Blue is an example, a very large plan in Florida, where the language has been buried in the plan for years and suddenly sprung on consumers without any notice. We've had other Blue Cross plans across the country actually apply it retroactively in the middle of the plan year. So another very unfair situation that just gives consumers no opportunity to prepare for it. Next slide, please. So how does this impact patients? Well, very severely. As Louise did an excellent job talking about earlier, the maximum copay or the maximum out-of-pocket limit for the coming year will be $9,100, up to $9,100. It's double that for a family. And if you get hit with the copay accumulator, that is taking away the cost-sharing assistance that you really relied on as a lifeline to be able to access the product that you need. Suddenly, completely by surprise, that's no longer available to you. And for many people with a bleeding disorder, the cost of their blood clotting factor is going to be way above that 9,100, even the first time that they require it during a calendar year. So they're going to show up at the pharmacy, call the pharmacy, and find out that if they want access to their product, which they need imminently, they can't get it unless they can write a check for that full out-of-pocket amount, the $9,100, and very few people can do that. So this has huge consequences on patients because they have to go into debt, borrow from others to try to come up with this amount, or have their treatment suddenly disrupted. And that disruption can cause all types of obviously adverse health outcomes if they have to go to the emergency room. It can cause them significant injuries to their joints. It can even be fatal for head bleeds. Those can cause significant amount of time out of school or out of work. All of these things have even long-term consequences on families where they're having to come up with this money every year. They can't afford a house. They can't afford their kids' education. They can't save for retirement. So it really exposes them to significant costs that are just unaffordable for most people. Next slide, please. So maximizers, how are they different? Well, it's just a form of accumulators that hits patients less abruptly. The impact is spread out over the calendar year. That does not mean that it's better or less, not at all. Whether you're getting hit with maximizers or accumulators, the impact is largely the same. The money is not applied to your cost-sharing obligations. You cannot benefit in any way from your copay assistance. What happens with the maximizers is it's actually a method that insurers have come up with to go after your full copay assistance, not just the $9,100 out-of-pocket limit. So if you're getting $12,000, for example, or more, $20,000 from a manufacturer for the cost of your drugs, they can go after that full amount. They will take that full amount. The $20,000, for example, they will divide that by 12 so that they will set your monthly copay for your prescription drug at 1/12 of your total manufacturer assistance for the year. And then none of that will count to your deductible or your out-of-pocket maximum for any other treatment or services that you need. Again, many times completely without your knowledge or without any notice. And the other avenue that they've come up with to try to get around the ACA's consumer protections is to actually declare specialty drugs like clotting factor non-essential. Louise talked about the 10 categories of essential benefits that plans have to cover. Prescription drugs were one of those. Nowhere in the ACA does it say that specialty drugs are non-essential. This is something that health plans have just come up with on their own. And they're saying by doing this, they don't have to comply with the ACA's limits for out-of-pocket costs. They don't even have to comply with state prohibitions on copay accumulators that we'll talk about in the next slide. And so it's really a way for them to get around that and go after as much of your copay assistance as they possibly can recover and pocket it for themselves. So what happens is the patients are presented this as an optional program when in reality it is anything but. They are forced to enroll in this program, or they are denied coverage at the pharmacy, forced to pay extremely high coinsurance amounts for their medications, and really given no other alternative. The insurers, in fact, make it sound like something that's beneficial to the patient, again, using very deceptive names, variable copay solutions, for example. Next slide, please. So just visually, this repeats a lot of what was in the previous slide, but it's kind of a helpful visual, we hope, of explaining exactly the copay maximizers and what happens with, we're calling it a loophole, but it really isn't. It's just the insurer's own interpretation of the ACA. And they're basically, as I described, declaring specialty drug is non-essential. They're saying that you're not subject, that drug is not subject to any of the essential health benefit protections, including the cost sharing limits under the ACA, taking the full value of your copay assistance, dividing it by 12 by each month, so spreading out that cost, and then applying none of it to your cost sharing obligations. You don't benefit in any way. And again, they're being forced to enroll in these programs or pay extremely high copayments. Next slide, please. This is a question that we get quite often. How can insurers do this? Surely this can't be legal. Unfortunately, the reality is that under the current laws, there's nothing in federal law or regulation that specifically prohibits this. And in fact, the Centers for Medicare and Medicaid Services has specifically allowed plans to do this over the last few years. And so there's really not a lot of avenues so far for attacking it under existing laws. We are seeing two very large lawsuits that were filed this year. We'll have to wait to see how they play out, that have tried to attack it under other various state or federal laws that are out there relating to unfair business practices or especially deceptive trade practices. As we mentioned, you have these health plans using very deceptive names and attempts to hide the ball from insurers by burying it in plan documents. Could that potentially be prohibited as a deceptive trade practice under some of these existing laws? We don't know. We will see how this lawsuit filed by J&J, a drug manufacturer, plays out. It was filed against one of these mystery third-party entities that are affiliated with PBMs that are operating these maximizer programs. And so we really want to see what happens with that. These are entities that most of us have never even heard of, but you've heard of the PBMs that they're affiliated with. They're some of the largest around. Express Scripts, for example, uses this Save On SP. CVS uses something called Prudent RX. There's many others out there. Shark RX is another one that if you see that name, beware of, because these are these mystery entities that are basically going to these PBMs and telling them, hey, we found a way for you to, very upfront about it, quote, fully leverage all the manufacturer assistance dollars to offset your plan costs, end quote. So they're saying, we found a way for you to take all the money you can from patient copay assistance and use it for, profit from it, use it for your own bottom line. There's another lawsuit that we're closely watching that was filed by the HIV and Hepatitis Policy Institute and several diabetes groups. And they are attacking CMS for, as I mentioned, allowing the copay accumulators to go forward in their regulations. CMS initially proposed back in 2019 to prohibit copay accumulators and maximizers in cases where there was no generic alternative, which is a situation with most specialty drugs, including those for bleeding disorders. CMS reversed itself, and so these groups have filed suit over that, basically saying, there's a procedural violation under Federal Administrative Procedures Act, and it also conflicts with the cost sharing definition under the ACA. So something we're closely watching because we're, hopeful that they can find a way to attack these under existing laws. But otherwise, we're trying to pursue new federal and state laws that I'll get into here. Next slide, please. So 15 states already, plus Puerto Rico, have acted fairly quickly within 2-3 years to prohibit copay accumulators and maximizers. In all but 5 states, these have been across the board prohibition. 5 states have created kind of a compromise position where they only will do so when there's no generic alternative, kind of following CMS's initial approach. We do have another probably 8 to 10 states where we are hopeful to have legislation introduced for our next session. We've had 3 this year that were added: Washington, Maine, and most recently Delaware. And we are really hoping to have our largest state to come on board in New York. There was a bill that was passed by the legislature earlier this year that has yet to be signed by the governor. It seemed that she was waiting to see if she would be reelected or not. Now that she has, we're hoping that that would come on board, because so far, these 15 states account for 11% of the commercial market, consumers in the commercial market who are now protected by CAAPs. But unfortunately, state laws can only do so much. They can only regulate state-regulated plans. That's individual plans, small group plans, state employee plans. They can't touch the large group market or the self-funded plans. Those are regulated by the federal government through a law called ERISA. And that's what we are really hoping to pursue a federal fix to address that. Next slide, please. And there's two approaches we're taking at the federal level. One is with CMS, because this is something they could address at any time through their rulemaking. This does not need a new law from Congress by any means. And so we are hoping that they'll reconsider their earlier decision to back off their proposal to prohibit it, at least for cases where there's no generic alternative. It really seemed like CMS, because they allowed these state laws to go forward, we're taking a wait and see approach to see how much momentum there was at the state level. So now that we're getting to 15 or 16 states and hopefully more than 20 by next year, hoping that's enough to really spur them to action. But if not, we did have legislation introduced this year, bipartisan legislation, HR 5801, the Help Copays Act, that would provide the federal fix that we really need, because this would apply across the board, all 50 states, all plan types, state or federally regulated. It would prohibit both accumulators and maximizers in all of those plans. And it would eliminate this non-essential health benefit loophole that we were just talking about. Next slide, please. Now, as I was starting to mention, states can only regulate about 20% of the privately insured consumers. They can only go so far, and that's why we really need that federal fix. Large groups, self-funded plans, they can't touch. And that, of course, is where we are seeing the fastest growth now in these copay accumulators, especially in the maximizer model. That has essentially taken over accumulators in large group plans. Some 60% of large employers now have some form of CAAPs, and that is going to grow very quickly. And so we are really hoping that that federal bill, which has stalled for this year, but will be reintroduced next session, will provide that type of federal fix that we need. Next slide, please. And the language I talked about that's in the federal bill that would ban the essential benefit loophole, the copay maximizers that we're talking about, is very simple. It's really just clarifying that there is no loophole there. And it's just saying that the plan can't alter the terms of the coverage based on the amount of somebody's financial assistance that's available to them. So it's something that is in the federal bill and should be in any of the new state bills that are being introduced for next year. Next slide, please. So one thing we really struggle with is patient stories. That's what's really critically needed to make a difference on this issue. There's a lot of false narratives out there that are being put out by health plans, and we really need patients to talk about the type of impact that accumulators have on them, especially those with bleeding disorders who are going to be forced to pay out of pocket far more than lawmakers are led to believe by insurers. And so some of the things that, some of the reasons we struggle with finding patient stories are, it's just very hard for patients to recognize sometimes that they're being hit with a copay accumulator, and it's a complicated issue to explain. So it's hard for them to also be able to advocate for some of the needed changes. So we try to put together some really keywords, some talking points that can help them in telling their stories. And one of the most important is just to really stress that this is essentially a lifeline for them, that there is no way for them to afford a blood clotting factor if they don't have this copay assistance available to them. That removing this lifeline, it just makes it impossible, if not extremely difficult, for most people to be able to continue on the treatment that they need. So when they are having an acute bleeding episode and they need that factor immediately, that they can't have that care disrupted because completely by surprise, that lifeline they thought was available to them has disappeared, isn't there. And they have to somehow borrow, come up with $9,000 in order to afford their treatment. The other thing to really stress is the fact that insurers are what we call double dipping. They're getting paid twice. They're taking the copay assistance, pocketing it for themselves, and getting paid again from the consumer for their cost sharing obligations. And one of the most important points is the fact that the only people who really oppose prohibiting copay accumulators are the health insurers themselves. This has nearly unanimous, if not unanimous, support among the states that have passed it. It hasn't been a Democratic or Republican issue in these states. It is strongly supported by all of the provider groups. It is something that just has extremely wide support from anybody except for insurers. Next slide, please. And some of the false narratives that I talked about that you will hear when you go up to talk to lawmakers about this issue. One is they'll throw out the fact that copay assistance somehow distorts the marketplace because it's incentivizing consumers to buy higher cost brand name drugs instead of lower cost generics. Obviously, in the case of bleeding disorders and most any specialty drug, there are no generic alternatives available. There is no way for them to purchase a lower cost drug if they did not have the copay assistance, if that's taken away from them. The presence of copay assistance and the banning of them by states is not increasing premiums in any way. The AIDS Institute has already compiled data showing that in the initial states, there were no change in premiums when consumers were protected from copay accumulators. It's also, critically important to, you always hear insurers tell lawmakers and lawmakers tell you the consumers need to have more skin in the game. That's the term they like to use. And when you actually confront them about that, ask them what that means, they will tell you, oh, well, they need to pay, something out of pocket, $500, $1,000 towards their care. So they're, being responsible consumers. Well, they don't understand in the context of bleeding disorders. You have these costs over a lifetime. The cost of your drug is far more than the out-of-pocket limit. You're going to have to write a check for $9,100 or $1,800. And when you ask them, do you know anybody that can do that? They start to understand that argument really doesn't hold a lot of water. And other things we emphasize are the fact that this isn't mandating coverage for insurers. This isn't driving up their costs. They're free to do cost containment or other prior authorization methods. What they cannot do, what these laws are closing off, is the new avenue of discrimination that they found. It's not letting them drive the cost of the plan as high as possible for their highest cost consumers. And that is the most important fact probably to stress. Next slide, please. So just real briefly, because I know we're running short on time, it's important to point out that this is something that is not a hemophilia only issue or a bleeding disorders issue by any means. Anybody with any type of serious health condition who relies on specialty drugs is going to have a very significant adverse impact from accumulators and maximizers. There was a very good article a couple months ago in September in the Washington Post describing the impact of one of these maximizer programs on somebody with lung cancer. But it's just good that the awareness of that is out there and increasing, and a key point to make when you talk about this issue with lawmakers. Next slide. So what can consumers do to try to identify copay accumulators in their health plans? Well, like I talked about, it is extremely difficult. And no one expects you to be able to do this, but the key thing is there are some tips that you can follow that can probably help you look out for some warning words, some things to watch out for. And one of them is not to rely on the term copay accumulator. You probably will never find that in your plan document. But you can go to what is called the summary of benefits page. It's something that all insurers are required to put on their website and mail to you, and look for the explanations related to your annual deductible and your out-of-pocket maximum for certain keywords that we'll get into. Search the plan schedule of benefits as well, and the pharmacy limitations and exclusion sections, and look for things like copay coupons, manufacturer coupons, copay assistance, discount prescription cards. These are the types of things that insurers are really trying to attack. Many conditions like rheumatoid arthritis, for example, actually have these copay cards that are loaded by manufacturers with a certain amount of money on them. And that's what insurers are really focused on when they created these accumulator programs. And so you may actually see those terms in your plan documents. And if you do, be careful. They probably relate to an accumulator. Other terms to be aware of right away are anything that says copay solutions, copay protection. Again, things that sound beneficial to you and are not. So if you see those, that's another red flag. Next slide, please. So one of the most important things to do, especially during open enrollment, when you're selecting plans and you're trying to find out if one of these accumulator programs exist, is to actually call your insurer and ask them. That can often be the best way to find out. But again, don't use terms like copay accumulator, copay maximizers. The phone reps at these places are probably just as unfamiliar as you are with those terms. The key thing to ask them is, will my copay assistance count? Will it be applied to my annual deductible and my annual out-of-pocket maximum? And get that in writing if at all possible. They may not be required to provide you any type of advance notice, and at least that would give you something to show later on if they do decide to spring this on you in the middle of the plan year by surprise. The other key point, Louise did an excellent job of stressing this. It's especially true when it comes to accumulators and maximizers. Do not simply auto-renew your plan during open enrollment. Plan terms change very frequently. And just because you did not have an accumulator in your plan next year is no guarantee at all that it won't be sprung on you for that coming plan year. As I mentioned before, very often that language can be buried in there and be applied at any time. And so very important to do your due diligence every open enrollment session. We talked about nonprofit assistance a little bit. There are only a handful of plans where we have seen language actually prohibiting copay assistance for nonprofits. Most of it is targeted to manufacturers. Molina is one of those where we've seen the language apply to nonprofits. But in most cases, that assistance should still be available to you. So if you don't have any plan options that have no accumulators, that's certainly the first place to start. See if there's a nonprofit foundation like a PSI, a PAN, the assistance fund that would still be able to help you out depending on your income. And of course, be an advocate. If you have a patient story to tell, that is something that is extremely helpful. Even if it's not being applied to you, tell them what it would mean to you if an accumulator were to be applied under your plan. Next slide, please. And the last slide is just to let you know that there are some avenues out there to file a complaint. But again, since there really is no existing federal law, or in most states, no state law prohibiting accumulators, you really wouldn't have any recourse against the accumulator itself. But many states have requirements for advance notice relating to cost-sharing obligations. Health plans may not be able to change the design of their cost-sharing under their plans without notifying you in advance. They also would not be able to change it mid-year without notifying you in advance. So if you do get hit with one of these, it may be worth checking with your state insurance commissioner to see if at least the advance notice would have to be required. And that could potentially reopen enrollment for you during a special enrollment period if they haven't complied with that. The other thing is many states have laws against discriminatory health benefit designs. And copay accumulators certainly falls under that. If an insurer is trying to make a plan as unaffordable as possible just for people with a specific condition, like bleeding disorders, that's something your state insurance commissioner may get involved in enforcing. And unfortunately, if you're in a large group or self-funded plan, you have to go to the Department of Labor. That's the entity that enforces the ERISA standards. And we put 2 ways to do that here on their website. They do have a telephone number as well. Obviously, going through either your state insurance commissioner or Department of Labor is a slow, time-consuming process with probably a low likelihood of success, but it is, a place that you can turn to if some of these notice requirements especially aren't being followed. The last alternative you probably have is your HR department. This is always a tricky one for employees. Obviously, for people with a costly condition like a bleeding disorder, retaliation is always a very serious concern, a very legitimate concern. So, this is something where you really would have to get a sense of your own employer. Are they a bleeding disorder organization? Are they a disability-related organization that may be, sensitive to how accumulators are impacting you? They may not have been aware that an accumulator is under their plan, but particularly for a self-funded plan where they create the benefit designs, there are potentially some things they could do for you to help if you're in this situation. But again, you know your employer better than anybody else, and you know how receptive they may or not be to that. There's always a risk when you go to your HR department, and so that's a decision that you may want to talk with somebody before you take that step. Next slide. And if there are any questions at this point, happy to entertain them here.
Thank you so much, Mark. I'll be that infamous person, not a question, but a comment. When you talked about discrimination and the possibility of raising that with your state agency, it is also a line that HFA and coalition allies are pursuing at the federal level. The Federal Department of Health and Human Services just published a new kind of reinvigorated non-discrimination rule that applies across health plans, self-funded and marketplace. And we have made the case in comments on the non-discrimination rule that copay accumulators and maximizers constitute discrimination.
Yes, an excellent point, because CMS would be the place to go to if you were trying to allege discrimination in a marketplace plan for those reasons.
So one question was just, what can I do if I get insurance from work and the only available plan offering includes an accumulator?
So as we just discussed, the nonprofit foundations, the copay assistance should be available for you there, unless you're under these handful of plans that are attacking nonprofits. But Molina, to our knowledge, is the only one, Molina Health Plan, that actually has that in their language. So if you meet the income requirements, nonprofit foundations would be the first place to check. But unfortunately, if all of your plan options have accumulators, there's not a lot you can do unless you can certainly check with your manufacturer about other alternatives that they're aware of. But the first place to start would definitely be a nonprofit group. And
another question was, I understand that maximizers are more commonly seen in employer or union plans. Can you just elaborate on why that is?
The large group self-funded plans are not able to be regulated at the state level. They're only regulated by the federal government under ERISA. And they have found, like we were talking about, this loophole for getting out of the ACA standards under those plans. A number of large group plans don't have to comply with the essential health benefits. Most of them do. But it's really the individual and small group plans that have to. So you have less, large group plans have less requirements that they have to follow. And so a number of these maximizer programs have flourished there because there's fewer obstacles for them to implement them.
Well, thank you very much.